Hello. This video log aims to explain the empirical evidence supporting the claim that lower socio-economic status causes worse health. Firstly, this graph shows the high number of deaths and their causes in York, 1898. Due to the poor socio-economic climate in the late 19th century, there were a lot of fatalities under the age of 5. This is because of low quality living conditions such as the lack of running water and sewage systems, in addition to the lack of immunisations. As you can see, the red line points out that there is a high amount of deaths due to tuberculosis and other respiratory diseases. This is significant due to the massive industrial factories in the vicinity of the city because of majority of citizens in York were working class. A similar analysis was carried out post-war. Because of the creation of acts such as the NHS in 1948, poverty decreased by approximately 5% due to the NHS creating new jobs and curing those that were unavailable to work due to illness. Overall, the action taken by the government as a consequence of the high poverty rates caused lower rates of death, which shows a direct correlation between lower socio-economic status and worse health. This next diagram shows life expectancy at birth of people in England and Wales from 1841 to 2011. As you can see, there has been a vast increase in life expectancy since 1840. To break this down, there is a steady increase from 1849 to 1890 until a sudden escalation occurs in the data until the 1950s, raising the life expectancy of men to 66 and women to 71 years old. This is due to the development and more extensive use of immunisations such as vaccines to eradicate diseases such as measles, mumps and rubella. As a consequence of this, there is an improvement of life expectancy at birth of 20 years for both males and females. Furthermore, from the 1950s to 2010, the life expectancy continued to improve due to the progressively fewer families under the breadline and the development of medical treatments which provide vital healthcare, crucially for the older generation and related illness like heart disease. So in 2011, life expectancy at birth has almost doubled what it was in 1841. This next graph compares family income and relative risk of premature death, which is at the age of 65. The blue line shows the relative risk of having a premature death, which is equal despite income levels. However, the results reveal a negative correlation, meaning that the lower the family income, the higher the chances of premature death. Therefore, this graph provides strong evidence that the lower an individual's global social economic status, the worse their health. This could be caused by factors including living conditions, as overcrowding can often spread diseases. Also, access to private healthcare, which is of note as this data is from the United States, where healthcare is not supported by the government but by the individual. In conclusion, an individual is over 3 times more likely to die prematurely if they are earning less than $10,000 a year as opposed to $100,000 a year, as they set the minimum relative risk because social economic status has not been found to have an impact on one's health beyond that level of earning. Similar tests have been carried out in other countries that also support these findings, as shown here. Finally, this is a table that shows death rates based on gender and social class in England and Wales 1971. It is shown in rates per 1,000 people on average. The Black Report states that occupations can be categorised into 5 tiers: professional, being the most qualified job, intermediate, skilled, non-manual and skilled manual, which have been grouped into the same tier, partly skilled and unskilled. The less skill that the job requires, the higher the death rates. This is because of factors such as more strain on the body in manual labour. This is also a clear distinction between males and females, as males are proven to have a higher death rate in all tiers. However, the increase in death rates for females is only 3.16 in this data, whereas for males it is 5.9. This could be because the data for females is based on their husband's occupation, so it is an indirect consequence of job-related illnesses, as well as these females living in more stable environments compared to the males used in the study who could be unattached.